Hello doctors, welcome back to my channel. Previously I have discussed about the SLE in the connective tissue disorders. Now today I am going to discuss the next topic is rheumatoid arthritis. I hope you guys are familiar with this topic, and the first I am going to write what are the connective tissue disorders. I just have mentioned in the previous video as well. Now also I am going to write it the same thing. Connective tissue disorders. In under the connective tissue disorders, first topic I have completed is SLE, and the second topic today we are dealing with that is rheumatoid arthritis, and the third and fourth topics will be, the fourth topic is gout and third topic is scleroderma. The first, let us start with the rheumatoid arthritis. So whenever the rheumatoid arthritis comes to your mind, what do you think? What does this problem do to our body? So firstly, the rheumatoid arthritis is an autoimmune condition. SLE is also an autoimmune condition, and still the rheumatoid arthritis is also an autoimmune condition. What does the autoimmune means? The autoimmune means our own immune system, own body is affecting our own body tissues and damaging our own body cells. It is an type 3 hypersensitivity. What does a type 3 hypersensitivity means? It forms an immune complexes that will damage our own body tissue. Type 3 hypersensitivity will form immune complexes that will damage our own body tissues. But in rheumatoid arthritis, it will affect females more than the males. In females, can you tell me the age group? It was a middle age, like 20 to 50 years females. Okay, and it is HLA-DR4. And whenever the lady comes into the OPD, what was the first complaint she will tell to the doctor is, Doctor, I am having an stiffness in the fingers whenever I am getting up in the morning. This is the first complaint she will tell the doctor. The first complaint is the morning stiffness. The morning stiffness is the first complaint she will tell to the doctor. Try to remember this point, morning stiffness, which will reduce physical activity of that female. It will reduce physical activity of female. And in rheumatoid arthritis, it has an articular manifestations and extra articular manifestations as well. What does this extra articular manifestations? Other than the joint problems, it will also involve other body parts as well. That's the meaning of extra articular manifestations. So I'm going to write the same thing, whatever I have said just now is RA means rheumatoid arthritis. It is going to affect the joints, that was articular manifestations, and it is going to affect other than the joints, that was extra articular manifestations. In that, the most common extraarticular manifestation is rheumatoid nodule. I am just going to share you the rheumatoid nodule. How does it looks like? The rheumatoid nodule is mostly seen on extensor surface. Let me share you how does the rheumatoid nodule looks like. See, see, this is a rheumatoid nodule. See here, this is a rheumatoid nodule. It was, when we palpate that, it was tender and firm. It is an immobile. It cannot be moving. It is very hard in nature, and it was mainly seen on the extensor surface. So this is the most common, okay, and it will also involves other organs other than the joint. That was an extra articular manifestations. First we will deal with the articular manifestations. Initially the rheumatoid arthritis will only involve small joints, and later it involves the large joints. Okay, rheumatoid arthritis first involves small joints initially, but later involves larger joints. This is an bilateral problem. Whenever the lady complains, she will complain she is having an stiffness in the both hands, not in the single hand. Try to remember this point. She will complains she is having problem bilaterally, and the problem is symmetrical, but in SLE it was asymmetrical, only unilateral. Okay, if one joint involved, then that was called as monoarticular. Mono means one, that was monoarticular. If less than 4 joints involved, then that was called as oligoarticular. Okay, if the joints more than 4 are involved, then we will call it as polyarticular. Okay, then we completed the articular manifestations. Just this is very simple. First, whenever the rheumatoid arthritis involves a joint, the small joints involved initially, and later the larger joints involved, and it is a bilateral problem. It is a symmetrical, and it involves one joint, then that is called monoarticular. If it involves less than 4 joints, then that is called oligoarticular. If it involves more than 4 joints, then that is called polyarticular. And in extra-articular manifestations, the first syndrome we are going to discuss is an Kaplan syndrome. The first syndrome is Kaplan syndrome. In Kaplan syndrome, it will mainly affect the lungs. That was the rheumatoid arthritis along with pneumoconiosis. Pneumoconiosis. What does this mean? In that, specifically it will affect simple coal worker pneumoconiosis. This is, let me write it, let me expand this abbreviation. Simple coal worker pneumoconiosis. This is Kaplan syndrome. This is very important. From here the question we can expect. And next syndrome I am going to deal is I'm using the blue color. The second syndrome is Felty syndrome. In Felty syndrome, rheumatoid arthritis associated with an massive splenomegaly. Rheumatoid arthritis along with the splenomegaly, then we will call it as Felty syndrome. Don't go deep into these topics. You just remember rheumatoid arthritis associated with the pneumoconiosis, then we will call it as Kaplan syndrome. If the rheumatoid arthritis associated with the massive splenomegaly, then we will call it as Felty syndrome. That's it. Massive splenomegaly. This is Felty syndrome. And next, the most important thing is, what is the hallmark feature? What is the hallmark feature of rheumatoid arthritis? This is flexor tenosynovitis. Let me show you the picture of this one as well. See here, I am just going to explain it. Here in the flexion area, there was a tendon. This tendon got inflamed. See the redness. There was an inflammation here. That's why the patient cannot flex the finger. That's the reason whenever she wake up in the morning, she will be having a morning stiffness. This is called as flexor tenosynovitis. In the name itself, there was an thing, there was a problem in the flexion, and teno means tendon, and there was a synovitis. There was an inflammation that was causing an inflammation in the tendon of an flexion region. That's why there was a problem in the flexion. So the patient hand remains stiff in the morning. This is called as flexor tenosynovitis. And if you see the flexor tenosynovitis, that will decreases the grip. Like when we ask the patient to hold the bottle, she cannot hold the bottle because there was a loose grip. She cannot flex her fingers. So that's why the grip decreases, and range also decreases, and movement also decreases. So I'm going to write the same thing, whatever I just said now. Here the grip decreases and the range decreases and the movement also decreases. This is flexor tenosynovitis. This is important, guys. You need to remember for sure. And next, we are just going to deal with the deformities. The first one is swan neck deformity. The swan neck deformity. The first swan neck deformity. I'm just going to show the images. By showing that images, you'll get to know what was the swan neck deformity, how you can differentiate that swan neck deformity from the botanized deformity. These two are the image based questions. You can get it in the exams. You need to identify those two deformities. The first one is swan neck deformity, and this one is botanized deformity. So I'm just going to differentiate this swan neck deformity and this botanized deformity. See, I'm just going to write in the image itself. So let's say where is the DIP joint? You just tell me where is the DIP joint. I hope you know, guys, this is DIP joint. Where is PIP joint? This is proximal area, so this is PIP joint. What is this PIP DIP? PIP means distal interphalangeal joint and PIP means proximal interphalangeal joint. And here in this patient there was a flexion here and an extension you can see in the PIP. Okay, F means flexion. There was a flexion in the DIP joint and there was an extension in the PIP joint, and this is called as swan neck deformity. I am going to write here swan neck deformity. You just remember the small mnemonic FES. FES. FES means flexion of DIP, extension of PIP. That is swan neck deformity. I am going to tell you one more deformity. That was an botanized deformity. This is botanized deformity. In the botanized deformity, it is completely opposite. Let me write it. It is completely opposite. Just say this is DIP as we know. This is PIP. We know this one as well. And here there was an complete, you see this in the joint, there was an extension here and there was an flexion here. This is the difference between the swan neck deformity and botanized deformity. You need to remember these two images. For sure, you will get one question in the exam. Okay, and there are two more deformities as well. The first one is mallet finger. Okay, I'm just going to show you the mallet finger as well, how it looks like. mallet finger. The mallet finger means there was an hyperflexion of the DIP joint. There was an hyperflexion of the DIP joint. See, I'm just going to share you the image as well. See, see here, there was an hyperflexion of an DIP joint, that is mallet finger. And next one what we are going to discuss is Z line deformity. Z line deformity. Under the Z line deformity, I'm just going to show you the image. Before that, try to recall what was the Z line deformity. It was something related to the thumb. Thumb looks like Z shape. Do you got the idea? See what happens here. Usually our thumb doesn't looks like a Z shape, but here the Z line deformity, the thumb looks like a Z shape. What happens here is there was an subluxation of first metacarpophalangeal joint and hyper extension of IP means interphalangeal joint. I'm going to show you the image and I'm going to explain you how does it looks like. See here. See here. Here there was an subluxation of the first MCP joint and there was an hyperextension of interphalangeal joint. This is causing Z shape. That's why this is called as Z line deformity. After knowing the clinical features, we are going to diagnose like the patient is having rheumatoid arthritis or not. First, what is the test when it comes to your mind? What was the test we are going to do whenever the patient comes with the bone problems? What is the first test we are going to do for the patients? Like for a fracture, if a patient comes into a OPD, what is the first test you will order for the fracture of a bone? Yes, you guys know it. That was an X-ray. The first test we are going to order is in the diagnosis is made by the first step, that was X-ray. By doing X-ray, you will get to know there was an inflammation in synovium. Why there was inflammation in the synovium? Because our own immune complexes comes into that synovium and damages that synovium. That will cause erosions in joint that leads to the formation of the most important point is pannus. Pannus is formed. So I'm just going to show you how does this pannus looks like. So just try to remember this word pannus. See, this is the pannus. These are the immune complexes comes into the synovium and the synovium is an thin layer of the synovium joint. So it damages the synovium, that causes inflammation of the synovium. By causing the inflammation, there was an inflammatory mediators comes into this place and there was an macrophages present here and there was an exudative fluid released, and this exudative fluid mostly contains WBC cells that will further damages the joint and further cause inflammation and further restrict the movement of the joint and causes pain. That's the complaint the patient tells the doctor. So that forms the pannus. And the second one is the criteria. We just need to know the criteria. For that criteria, I'm just going to give you the mnemonic. That was Sajid. The first we done with the X-ray, and the second one we are just going to deal with is the criteria. That was the Sajid. The second one is criteria. Based on this criteria, we are just going to give the score. Like each point has a different score. By doing all this, by examining all this, we just give the score. If the score is more than 6, then we can confirm the patient suffers from rheumatoid arthritis. So I'm just going to tell you even after this as well. The first one is Sajid. Sajid is not the criteria, it's just the mnemonic to remember what comes under Sajid. S and A and J and I and D. This is Sajid. Sajid in first, S stands for serology. So what we will do under this serology? Just try to understand. In serology, the first most specific antibody for the rheumatoid arthritis, the most specific test we are going to do is anti-CCP antibody test. I hope you guys remember this point. Whenever the patient walk into the clinic, we need to diagnose the rheumatoid arthritis. First, the most specific test, the one and only specific test to diagnose if the patient is rheumatoid arthritis or not is anti-CCP antibody test. Anti-CCP means cyclin citrullinated peptide test. Don't do RA and confirm the patient he is having rheumatoid arthritis. You are absolutely wrong. If you do just the RA factor and you will confirm the patient is having rheumatoid arthritis, no. RA factor can be positive in many conditions. Okay, don't confirm if a patient is having only a rheumatoid arthritis by doing RA. Okay, but if you do anti-CCP, if the anti-CCP is positive, then patient suffers absolutely, he will suffers from rheumatoid arthritis. Remember this point for sure. I'm just expecting a question like previously also. This is the most important topic, for sure you'll get one question from this topic. I'm just assuming you'll get a question from this topic. Okay, the most specific antibody for rheumatoid arthritis is, remember this, don't forget this one in your life, anti-CCP antibody. What is this anti-CCP? CCP means cyclin citrullinated peptide antibodies. Whenever there was increase in the anti-CCP, that leads to damaging our joints more, that causes rheumatoid arthritis. And after this, and the RA factor we are just going to do as a screening. RA factor is only for screening. I'm just going to write it as only for screening. Don't confirm by just doing the RA factor. Don't confirm the patient is only having rheumatoid arthritis. Okay, and the second one is acute phase reactants. Acute phase reactants. Here in acute phase reactants, A stands for acute phase reactants. I hope you guys remember that there are two acute phase reactants. One is ESR and the other one is CRP. These are normal initially in the rheumatoid arthritis patient, but later these two will increase. If these two increases later in the rheumatoid arthritis patients, so we can confirm the patient is having rheumatoid arthritis. Okay, here this one was early, but in later stages, if the ESR and CRP increases in rheumatoid arthritis. Okay, and next is joint involvement. These two comes under joint involvement. even there was small joints are involved or large joints are also involved. Large joints and small JTS means joints are involved here. But when we comes to the D stands for duration. Duration, it depends, like if it is less than 6 weeks or it can be greater than 6 weeks. So based on whole criteria what was mentioned in the Sajid, will give the score. If the score RA score greater than 6, we will confirm the patient is positive for rheumatoid arthritis. And after the x-ray, after the criteria, what we are going to do to confirm the patient is having the rheumatoid arthritis is, we are going to do an MRI scan. In MRI scan, we are going to notice some changes, and next test we are going to do is synovial fluid cytology. In synovial fluid cytology, if a synovial fluid has an exudate, if a synovial fluid or synovial fluid cytology, if the joint is having an exudative fluid, as I have already mentioned in the joint when I was explaining the criteria here, there was a formation of the pannus. Here, see, here there was an exudative fluid release. By the exudative fluid release, there we can see the number of cells. We just count the number of cells by the cytology. Here, if we count the number of cells, if the number of cells is like more than 5,000 and less than 50,000, so we can confirm the patient is having rheumatoid arthritis. If the cells ranges from, I'll just tell you the range, like 5,000 to 50,000 is the range. 5,000 to 50,000 is the cells range. If this was there, we can confirm the patient is having rheumatoid arthritis. After we diagnose the disease, if the patient is having rheumatoid arthritis, we confirm the patient is having the disease, then we are just going to treat the patient. Do you remember how we will treat the patient? Do you remember any drugs for the rheumatoid arthritis? Yes, I know you guys remember this. There was one name is DMARD. DMARD. What does this DMARD stands for? Disease modifying anti-rheumatoid drugs. In that, we are going to give triple therapy for the patient suffering with the rheumatoid arthritis. So, in this triple therapy, the first drug we are going to give to the patient is MTX, means methotrexate, and next one is sulfasalazine, and next drug for the patient is hydrochloroquine. These are the three drugs included in the triple therapy. Or if you want to give the patient methotrexate along with etolizumab, even this will work fine. Nowadays this was used as a treatment. And if it doesn't work with the triple therapy, still you can make the patient life better by giving intra-articular steroid injections. Just take the steroid into the injection and directly inject the steroid into the joint. This will give a short-term relief to the patient. And remember this one, it does not slow down the progression of the disease. It will only give the short-term relief to the patient. Steroid is just to give the short-term relief to patient. Okay, it do not slow down the progression. Slow down progression. I hope you guys understand this concept of rheumatoid arthritis, and within 5 minutes I'm going to revise whole topic now. Even if you didn't focus up to now, try to focus only for this 5 minutes. That will be good enough to solve your questions coming in the exam. Okay, first, today I just said about rheumatoid arthritis. Whenever it comes to rheumatoid arthritis, it is an autoimmune problem that was type 3 hypersensitivity. In type 3 hypersensitivity, that was an antibody and antigen immune complex, immune complex mediated, and it will affect the middle-aged females, and it belongs to HLA-DR4 category. Whenever the patient comes into the clinic to the OPD, the female first she will tell to the doctor is, doctor, morning when I get up from the bed, I have a stiffness in the fingers on the both sides. Okay, this is the complaint. She will complain to the doctor first. And whenever the rheumatoid arthritis, we are just going to study in that there was two types of manifestations. One is within the joints, that was articular manifestations. The other one is extra articular manifestations. It will not only affect the body joints, it will also affect the body organs as well. If it affects the joints, it will involve the small joints initially, and later it will involve larger joints. It is a bilateral and symmetrical problem. Whenever we are studying the SLE, that was unilateral and that was asymmetrical problem. Remember this point. And this only affect one joint, then that was monoarticular. If it affects less than 4 joint, that was oligoarticular. If it affects more than 4 joints, then that was polyarticular problem. Okay. Whenever we are dealing with the extraarticular manifestations, the most common extraarticular manifestation is rheumatoid nodule. This rheumatoid nodule is shown in the image. This is seen on the extensor surfaces only. And in extraarticular manifestations, whenever the rheumatoid arthritis associated with the pneumoconiosis, then that we will call it as Kaplan syndrome. In that pneumoconiosis, what was the specific pneumoconiosis we are talking about is simple coal worker pneumoconiosis. And next syndrome we are dealing with is Felty syndrome. Whenever the rheumatoid arthritis associated with the massive splenomegaly, then that was called as Felty syndrome. These two are most important. Try to focus here. Okay, what is the hallmark feature of rheumatoid arthritis? In rheumatoid arthritis, there was an flexor tenosynovitis. In the name itself, there was an answer for it. In the flexor, there was a problem in the flexor tendon. Teno means tendon, and synovitis, inflammation of the synovium. Here, there was an tendon problem, tendon inflamed. That's why the patient cannot flex the fingers. Okay, that's why if he asks the patient to hold the glass, he cannot hold the glass. That's why there was decrease in the grip, decrease in the range, decrease in the movement of flexion as well. That's why the patient's fingers remains stiff. That's why the female complains of morning stiffness of the fingers. Okay, so here there was two important deformities you need to remember. That was the swan neck deformity and Botanitis deformity. In swan neck deformity, I told you to remember with the mnemonic is FES. There was an flexion in the DIP and extension in the PIP, and swan neck deformity. S stands for swan neck. FES. And opposite to that was Botanitis deformity. In Botanitis deformity, there was an extension in the DIP and flexion in the PIP. Okay. And here is a mallet finger. In mallet finger, you see here there was an hyperflexion of an DIP joint. That was mallet finger. But here in jet line deformity, there was an subluxation of the first metacarpal joint, and here hyper extension of interphalangeal joint. This makes our thumb jet shape. That was called as jet line deformity. These four images are most important. They can be asked as an image questions as well. And I forgot to tell you one more most important point here is most important point here is here in rheumatoid arthritis, what is the joint spared? It is not involved. Can you answer me? What was the joint not involved. Joint not involved in rheumatoid arthritis is DIP, distal interphalangeal joint is not involved in the rheumatoid arthritis. Try to remember this point. This is most important point. Okay. And next, when we comes to the diagnosis, first we'll do the X-ray. In the X-ray, we are just going to find there was a formation of the pannus and there was an exudative fluid which contains lots of cells, that was an WBC cells, and there was an formation of the pannus. Pannus is most important. We need to remember this point. Pannus is important. And here, in by doing the X-ray, there we can see there was an inflammation of the thin synovial membrane that will cause the inflammation, and that will cause the erosions in the synovial joint, that will lead to the formation of this orange color pannus. Pannus contains lots of macrophages and exudative fluid and lots of WBC cells and lymphocytes as well. And next one is criteria. We are just remembering this criteria by the Sajid mnemonic. Here we are just going to do serology. First, the most specific antigen for the rheumatoid arthritis, antibody for the rheumatoid arthritis is anti-CCP. This is most specific and this is most important. You guys need to remember this point. This is most important. Anti-cyclin citrulinated peptide antibodies. Whenever these peptide antibodies are increasing in our body, that will damages our own joints and cause rheumatoid arthritis. So whenever we do anti-CCP antibody test, when it comes positive, then we will confirm the patient is suffering from rheumatoid arthritis. And one more point you need to remember, when you just do only RA factor, if RA factor comes positive, when you confirm if the patient is suffering with the rheumatoid arthritis, then you are absolutely wrong, because RA factor can be positive in many other conditions as well. So don't confirm the patient he is only suffering with rheumatoid arthritis by just doing only RA factor. You also need to do the most specific antibody test is anti-CCP antibody test. Okay. And next one is acute phase reactants. Initially, acute phase reactants are normal in rheumatoid arthritis patient, but in later stages these are also increased, that confirms rheumatoid arthritis. And there was a joint involvement, you can also know that, and there was a large joints and small joints are involved. But when we come into a duration, if there can be an less than 6 weeks or more than 6 weeks, by all these Sajid criteria, we are going to give the score for RA. That was if the score is more than 6, then we can say the patient is suffering from rheumatoid arthritis. And after that, we are going to do MRI and we are going to see the changes. That's how we are going to confirm rheumatoid arthritis. And we can also do synovial fluid cytology. By doing that synovial fluid cytology, we can see the exudative fluid which contains 5,000 to 50,000 cells. So if we see 5,000 to 50,000 cells, then we can confirm it as rheumatoid arthritis. Finally, the disease is confirmed it as rheumatoid arthritis. How we are going to treat the rheumatoid arthritis? First, we are going to give triple therapy, that was DMARD, disease modifying anti-rheumatoid drugs. In triple therapy, the first we are going to give is methotrexate. Along with that, we give sulfasalazine, and along with that, we give hydrochloroquine. In these drugs, which one is the drug which causes a side effect as an SLE? In the previous video, I have said the same point. There are SHIP drugs, SHIP. In the SHIP drugs, you remember this is sulfasalazine. This will cause SLE. Drug induced SLE is caused by sulfasalazine. Just remember this point. I am just recalling this point. And even you can also give methotrexate along with itolizumab. Okay. And after that, if the patient doesn't relieve by just only giving the medications, you can also administer intra-articular steroidal injections. By giving that intra-articular steroidal injections, it can provide the patient a short-term relief, but it do not slow down the progression of the disease. Do remember that. Okay. So this is all about rheumatoid arthritis. Try to recall this session, whatever I just said, the points. This is a simple way to teach you guys, and you just try to just revise the whole topic by putting my video in the 1.5 or 2x, however you are comfortable, and you can listen for one more time. You can recall all the things before going to exam. I am damn sure you'll score 100% in your exams, and wishing you all the best for your coming exams. And whenever you are just watching this video, and try to watch this video by having a 100% faith and confidence on me and on you. The what is the most important thing for the student whenever he was attempting an competitive exam is the confidence. You need to build a lot of confidence, so you can, even if you don't know the thing, when you answer the question with a 100% confidence, maybe by a grace mark, or maybe by your confidence, you will answer that question very rightly, and you can get that one extra mark. So you will feel yourself proud, and you will be mostly happy, and you make your parents and happy as well. Okay, so thank you very much for listening my lecture with your lots of patience. All right, thank you very much. Bye bye.